Just a few seconds. We are starting in. Okay, here we are. Good morning, everyone. Good morning from UK. Good afternoon to Asia Pacific and in Russia. Good evening in Singapore and Asia Pacific as well. So I'm your host, Dr. Sajid Malik again, and we are here into the 13th episode today of the ELSA Live TV channel. We have a master trainer across the globe, and let me introduce, first of all, my co-host, Dr. Rakesh Gupta, who is a professor of surgery and president of the Nepal Hernia Society, and he's a senior executive of the APHS, who have joined us as a co-host in this session. Welcome, Rakesh.
Thank you, Sajid.
Ladies and gentlemen, it is true privilege and honor to welcome one of the most distinguished leaders into the globally minimally invasive surgical platforms. And we are deeply honored to have with us Professor David Lumanto, who is the president of IFSAS, General Secretary of APHS and ELSA. He's a pioneer in minimally invasive and abdominal wall reconstruction. Professor Lumanto has played a pivotal role in shaping modern hernia surgery through innovation, education, and international collaboration. Sir, we are truly privileged to have you as the chair of this session. May I now invite you to share your opening remarks and set the stage for today's session.
Thank you. Thank you, Sajid. Thank you for organizing and for leading the ELSA TV live channel project. That is really proud because bring together a lot of experts from all over the world. You can see today we have Professor Zheng Lingji from Nanjing, that is one of the leaders in hernia surgery, not only in China, in Asia, but also worldwide. Similar, I can say for Rakesh Gupta, is part of the guideline project all over from a PHS from all over the world for the international guideline. And actually today we are very honored because we are first time involving a new part of Asia, Russia, and represented the Russian Hernia Society represented by Professor like Alexander Belosov from Moscow, but working in St. Petersburg now. I have a chance to visit him and doing live surgery, and I'm very impressed for the quality of surgery that they can offer. Dr. Sujit, that is still with us, and Dr. Sarfaraz, that is from India, that he will join us. Dr. Sujit is a deputy secretary of the APHS, and Dr. Sarfaraz is the Secretary General of the Hernia Society of India. So without further delay, and welcome all the participants to join us in this session. We are quite a good number of participants. I think ELSA is always very proud to host and share knowledge with all the experts and the participants from all over Asia. Sajid and Rakesh, I will pass the microphone to you and enjoy the TV.
Thank you. Thank you so much, Prof. Thank you. Today we have assembled an exceptional panel of experts, as Prof. Lumanto have given an introduction from Asia and beyond, and each have will bring the exceptional perspective from their national guidelines, clinical experience, and published research as well. So without any delay, I think we have gone through the introduction pass. So let me start with the first question. I think we can open the session. And let me throw this question to all of the faculties, basically to all of you, Dr. Alexander, Dr. Zheng, Dr. Sujit, and I think once Dr. Sarfraz would join us as well. Each of you is practicing in a different country, into the different setup. One is into the South Asia, one is into the Russia, one is in China, one is in Asia Pacific. So different nation, different ethnicity group, different surgical practice. So based on your national guideline and clinical practices, what is the single most under-addressed issue in complex abdominal wall reconstruction, which you have seen? I think I'll start with from the upper end. Dr. Alexander, you first.
Oh, thank you very much, Sajid. Hello, everybody, colleagues.
And I can't say about only one thing because the problem of large and complex ventral hernia in Russia is more actual than ever. The growing number of such patients present us with a significant clinical and organization challenges. In our practice, we use the full spectrum of abdominal wall reconstruction techniques. And first problem, what I think the perioperative patient management. In particular, our main problem in Russia, the use of botulinum type A, because in Russia, the available drugs don't officially include the indication for this procedure. So in most cases, we use it off labels. This creates both clinical and regulatory uncertainty. And the second big problem for us in our country, it's use of progressive pneumoperitoneum. This is a very effective technique, but there are still open questions regarding the implementation, legal framework, and reimbursement. So it's our big problem in treatment of complex hernia.
Yeah. What do you think, Dr. Zhang?
Sorry, can you please repeat some problems?
Can you hear me? Dr. Zhang, what's your opinion about
Sorry.
it? Zhang ji? Can you hear me?
Yeah. So actually, it's a good question. You know, according to the latest Chinese guidelines for diagnosis and treatment of abdominal wall incisional hernia that published last year, I think the most neglected, the single problem in the management of complex abdominal wall hernia is the insufficient implementation of systemic preparation, optimization, and the multidisciplinary team, the evaluation. So let's analyze these the core issues. Although the guidelines, clearly emphasize the importance of MTD discussion and the preparation, the conversion therapy for the patients with the complex abdominal wall conditions, like giant incision hernia with loss of dorming, obesity, and diabetes mellitus, or respiratory insufficiency, such etc. This step is often simplified or ignored in clinical practice for the following reasons. The one thing in our China is the unequal medical condition, because China's territory is very huge, very big. Different places, since the level of socioeconomic and medical conditions are quite different. So not all everywhere, like in the city of Nanjing, Beijing, and Shanghai. So this is one of the problems. The second one is that the cognitive biases, because some physicians they focus more on the technique in China law, itself, and the decision rule of preoperative optimization in the reducing postoperative complications. They still have some their own idea. So that means the surgeons, they focus on the technique, but they don't realize the optimization. The third one is difficult to implement, because such a question, you need some more time, like the pneumonia preparations. It requires the patient's collaborations, and also systemic management. Also, the economic, the medical fees in China. We have sometimes a very difficult system like DRGs, very restriction. So all these problems, I think, is a big problem for us. But I think we have the solutions, like we have to promote the MTD model. We have to encourage this model. And the second one is enhanced preoperative evaluations are very important. For such a difficult cases, we have the routine use of CT scanning to calculate hernia sac, even the volume, the ratio, and to get the correct decision making. The third one is, for some difficult cases, we have to use the conversion therapy. That means we have to modify the patient's condition and to find some correct or the suitable chance for the operations. So in summary, the shifting the focus on diagnosis and treatment from surgical skills to overall patient optimization is the most urgent, but most overlooked, the link to improve the efficacy of complex abdominal wall hernias. So this is my opinion. So thank you very much.
No, that's very comprehensive and very detailed overview of the subject. Welcome, Dr. Sarfraz, for joining us. And we were just talking about just setting up the stage in terms of the complex abdominal wall reconstruction, single most under-addressed issue into the 4 different components of the Asia. I'm just taking the narrative from the Russia, from China, from South Asia, from yourself, and Asia Pacific from Sujit. So looking forward to you. So what is the single most under-addressed issue in complex abdominal wall reconstruction in South Asia? You are mute, sorry.
So thank you, Sajid, and sorry about the goof up about a little bit of a time. But to tell you about the problem directly, I think our friends from Russia and China have put in a lot of words, and they're all very important statements. In our country, the complex abdominal wall reconstruction, obviously because of the neglected cases, the incidence is a little higher. I'm supposing it's higher. And the expertise is now gaining popularity, but where it is lacking is in uniformity. We do not have a uniform way of addressing these problems. And there is some centers would probably be doing more component. Some would think of peritoneal flaps. Some would be talking about prehabilitation in form of progressive pneumoperitoneum, some botulinum toxin. So it's a very heterogeneous way of managing things. And prehabilitation, I am totally in agreement with Dr. Zhengling Ji that we still need to have an MDT for prehabilitation and then take these patients for surgery. That's one of the most important areas that needs to be addressed. And finally, I think there is a lot of peer pressure to do these cases. I think it's a good idea to just know one's limitations, not in only terms of us being a surgeon, but also in terms of your logistics and infrastructure. If you think you're not adequately equipped, one should not take these cases. So I think these are the points that I wanted to add from my side. Thank you.
Yeah, no, thank you so much. Dr. Sujit, are you on board or?
No, I'm around.
Okay,
yeah.
Thank you so much. What's your narrative from the Asia Pacific point of view, like a single most under-addressed issue in the Asia Pacific region?
I think the main issue is these patients don't present to us in a timely manner, and also we don't have the MDTs as Prof. Chinjinli pointed out. So we need to have that MDT to discuss these cases, which is not happening very often. And we also need surgeons who can actually do the breadth of hernia repair, starting from the simple open repair, like there's an open IPOM, and up to peritoneal flaps, TAR, all these things together. You need to have the breadth of these hernia repairs. You need to know almost all the techniques available when you take on a case like this. If you only can do an IPOM, you shouldn't be taking on these cases. And so I think this is where the knowledge gap as well as the collaboration needs to be filled. Thanks.
Yeah, this is an excellent point. I completely agree with you. Like I think the whole faculty have agreed on one point. One is an adequate training, and second is bringing the case through the MDT, not going through the cases like for the complex cases to make a decision by yourself when you are actually in a real scenario. Thank you so much. I'll pass the mic to Dr. Rakesh, please.
Thank you, Sajid. So now I will proceed with the next session. So I will ask Professor Sarfaraz and Sujit. We have read your paper, Dr. Sarfaraz. I mean, the Delphi in 2024 from the India, you have published the Delphi consensus, which has established the role of various MIS procedure like IPOM plus, TAM, ETAP, Milos, SCOLA, TAP, LIRA, everything. And it all has all the options has various indications. But in another paper where the you two are co-author, you and Sujit, which was an international survey, and in those article, what we found that there is a slightly shift from intraperitoneal to retromuscular plane for around defect more than 4 centimeter size. So we know the reason of this contraindication of IPOM, but how a young surgeon or especially say novice surgeon should choose among all these procedure, and what is the reason in the paper which shows the shifting from IPOM to retromuscular plane. Thank you. My question to Sujit and Professor Sarfaraz.
Okay, so I think I'll go in first. So, as you know, globally, we have seen the shift of from intraperitoneal mesh placement to extraperitoneal mesh placement, especially the sublay layer. Based on the registry of Scandinavians, based on large databases, it was shown that the recurrence and the surgical site occurrences were favorable with sublay repairs. Therefore, there has been a shift. Having said that, there is nothing to take away from the intraperitoneal onlay mesh hernioplasty whenever the defect size is small and it is in the central area. So if you have anything in the midline, it's a W1 defect and maybe just up to 5-6 centimeters. It's possible to do intraperitoneal mesh placement, but beyond that, most surgeons now would go to place sublay mesh and do repair accordingly. So this comes from obviously registries and databases. Now, there is also a problem that this comes with more expertise if you want to do it MIS. If you want to do an open reef stopa, that is not a problem. But if you want to do the reef stopa through MIS technique, like an ETAP technique, TARM technique, and even TAPP technique, this will require considerable expertise. So as soon as we say there's a shift, we are also talking about shift of the expertise. So the surgeon becomes a very important factor. And now we are looking at the proliferation of so many centers which teach how to do ETAPs and how to do TARMs and TAPPs and even robotics, because we want to shift from intraperitoneal to extraperitoneal repairs. So I think the shift is coming at an expenditure of learning newer tools and making a simple surgery more complex also. We will have to strike a balance, possibly with more complex cases, and in terms of your own expertise. If you have a simple umbilical hernias, do your routine surgeries, do not make it more complex. Whereas when you have a larger hernia, think of sublay repairs, and probably if you want to do MIS sublay repairs, then you train yourself accordingly. And unless until this is something in evolution, I think in 5-10 years of time, we would see this. The other reason of doing sublay repairs in our country is because it is cheaper. When we do IPOMs, we have a mesh and a tacker. This costs about $1,000. Whereas if you are using a polypropylene mesh, it's $100. So it's a huge money saving. So whether we like it or not, a lot of surgeons would like to do MIS extraperitoneal repair even for smaller hernias. So it's out there. Everything is out there. The shift is there. The reasons are there. We have to evolve somehow and bring some back to you.
Yeah. Sujit, your opinion for this?
The only thing I would add to what Sarfaraz said is certain areas different approach. Subcostals and lumbar hernia, even sometimes the suprapubic region. You need a different way of handling this. IPOM or IPOM Plus is not the best option for this area. So most likely preperitoneal or your retromuscular with the TAR would be more suitable for these areas. These are challenging areas. Oh, thanks.
Yeah.
Yeah.
Thank you.
Thank you, Sudhir. So my next question to Dr. Alexander and Professor Zheng, like we know, many international consensus state that up to 8 centimeter of defect can be repaired with minimal SS surgery if the expertise is available and there is a moderate degree of agreement for this. So I want to ask both of you, like in your practice, up to 6 centimeter size defect and midline hernia, what is the what common MIS procedure you perform and what is the rationale behind? So I will ask from Professor Zheng and followed by Dr. Alexander.
Okay. So I think the most commonly used MRS for 6 centimeters midline incisional hernia repair is intraperitoneal only mesh, IPOM, in China now. You may ask why, because the first one is technical maturity and standardization. Because IPOM has been applied in China for nearly 20 years, so the operation process is standardized, and also the learning curve is very short, so which is suitable for the promotion in most small hospital, tertiary hospital or primary hospital and hernia centers. So this is the first one. The second reason is, I think, the minimally invasive advantages. We have the less pains, quick recovery compared to the open surgery. So IPOM is still has more advantages for small incisions, clear visions or less postoperative pains. So the third one is so even the open or some other techniques compared to IPOM, I think they have the results. So the effect is exact. So under standard operation, of course, have to standard operation. That means the approach covers the defect more than 5 centimeters, on exact fix reliably. So the recurrence rate is equivalent to the open surgery. It's almost the same. And the intra-abdominal adhesion can be treated at the same time. So this is the advantages. So also, if we're looking through the other guidelines like CGS in the United States, so also in our Chinese guidelines, so we all regard the IPOM as the standard procedures for the laparoscopic repair of abdominal wall hernias. In the midlines, the defect at about 6 centimeters. So of course, we can compare to the other MIS procedure like a TES or ETP. So theoretically, they have some advantages avoiding intra-abdominal mesh placement, but it is still limited to a few centers in China, not so popular, so due to technical difficulties. So long learning curves and also equipment requirements. So from these reasons, IPOM is still the first choice in my department, also for me, and also in China, so universally and cost-effective, and because also the reliability. So this is our experience, of course, but there is some trends, maybe in the next question. In China now, we have the trends from the IPOM to the sublay.
Yeah, thank you, Professor Zheng.
My answer,
And what's your view, Dr. Alexander, for midline 6 centimeter defect, the MIS?
Yes, colleagues, I want to separate my answer for 2 parts. My opinion and situation in Russia. If we look to this problem in common, unfortunately, in our country, open surgery is still the most performed approach for this type of hernia too. In smaller cities, procedures such as onlay repair are still occasionally used. Also, it's becoming less common. And we, before the last 5 years, until recently, IPOM was the predominant technique for defects up to 6 centimeters. However, there's a clear trend toward wider adoption for ETEP, reef stopper procedure, which increasingly being performed and activity longed by surgeons. But my opinion, it very depend which type of hernia we have with defect before up to 6 centimeters. For example, if it's not incisional primary hernia, we can look for ventral TPP. If it's lateral hernia, we should look to ventral TPP. If it's small incisional hernia, I prefer yet stopper maybe. But I'm also agree with Professor Chiang that IPOM are very popular and very common in Russia. We have same problems like in India, very expensive mesh and tackers, and it's I think most reason limited for IPOM. But our young soldiers, they prefer more often yet stopper, of course.
Thank you. Thank you very much. Sajid, now it's your turn.
Yeah, sure. Thank you, Rakesh. I have a question from Dr. Sarfraz. Thank you for earlier comment that we have talk about that we have seen a paradigm shift from open to minimally invasive surgery, and then initially we have seen for the small defect. Now we are seeing people are moving for the larger defect as well. Someone who is working in a hernia referral center, novice techniques like Botox, peritoneal flaps, or the pneumoperitoneum progressive techniques would be very familiar for those. But the people who are working in a general setup, like a district hospitals, who are doing these cases oftenly, what do you suggest to those people about using these novice technique, and what is your practice in incorporating these new modalities into the practice as well?
Yeah, Sajid, those are a lot of questions, but let me take it
I
slowly and
know.
one by one.
Thank you
I'll
so
not
much.
pant while I'm talking. Let's see. So, yeah, I think the bigger picture is that surgeons who were refusing cases about 10, 15 years back, this is too big a hernia, can't be operated, or I can't do this, or nobody can do this. Those answers have decreased. Some become zero, but those answers have decreased. We now do know that we can manage many of these complex, large hernias that we were not able to manage earlier. And these are thanks to a lot of surgeons who have worked hard and come up with fantastic options. So there are preoperative strategies and there are postoperative, intraoperative strategies which have improved tremendously. Amongst the preoperative strategy that you mentioned is botulinum toxin, progressive pneumoperitoneum. But I would say, let us talk about the bigger picture, which is prehabilitation. It has been emphasized, but it has to be re-emphasized. When we see these big hernias, they usually come in big patients, by which I mean 50% of them would be obese. And therefore, it has to be addressed along with the pulmocare, weight loss, either with medications or with bariatric surgery or something else. But this prehabilitation is a very important part in these complex hernias because they will translate into post-operative poor outcomes in terms of pulmonary embolism, myocardial infarction, recurrence, seromas, infections. So we need to work really hard in this area. Apart from that, two preoperative strategies like botulinum toxin and progressive pneumoperitoneum have come into existence I think globally, as far as I can understand, you can correct me if I'm wrong, botulinum toxin has become more acceptable because of its easy way of administrating. You can have your anesthetist do it. You could do it yourself by a little bit of training, ultrasound guidance. And that is why now the botulinum toxin into the trilaminar muscles is becoming more and more acceptable thing to do for all these complex hernias. On the other hand, progressive pneumoperitoneum are cumbersome, restricted to few centers, and somebody who's got a good team may like to combine both. I have not seen somebody using only progressive pneumoperitoneum, although I know a lot of surgeons who use only botulinum toxin. So somebody might use botulinum toxin and progressive pneumoperitoneum to increase the domain. That is possible. Uh, but it is cumbersome. If you have to have a catheter inside the abdomen, you have to instill air on a daily basis, and then it is uncomfortable for the patient and definitely not meant for all centers, unless and until you are really, really equipped and ready to admit these patients over long term. So coming back to botulinum toxin, this should be used because now if you have a defect which is more than 8 centimeters and you're looking for doing a TAR in these patients, and we know that the TAR comes with a price. It comes with a higher seroma rates, it comes with higher complication rates like injuries, and it may not be possible in all cases to do a safe TAR. So if we can minimize the TAR in our hands by using some preoperative strategy, then it makes sense. So botulinum toxin may obviate the usage of TAR. That's number one. Number two, it may also allow the defects, despite the TAR, they're not coming together. It may augment the medialization. So that's number two. Number three, it has arguably been shown to reduce the pain of the patient. And finally, the tolerance to intra-abdominal pressure, to abdominal compartment syndrome is much better. So these are various reasons why botulinum toxin should be used. At our center, for anybody with a hernia with more than 8 centimeters, we will either see if the patient looks okay for a peritoneal flap along with reef stopper, we will take them up for that, or we will do botulinum toxin and try not to do a TAR. So that is one, and we have fascial traction device as well. So fascial traction with botulinum toxin also works very well in getting the defect closure. So from our point of view, anybody from more than 8 centimeters, they either go for peritoneal flap technique or a botulinum toxin. With the botulinum toxin, we may get a reef stopper, can get away with reef stopper, or we may have a TAR, but this TAR will be easier to oppose, and we can get lesser pain, and finally we'll get more tolerance to intra-abdominal hypertension, and we use fascial traction.
I completely agree with you 100%. Exactly the same thing we are practicing in our hernia setup as well, like using the Botox as the first line. So I think the address is good. Like in terms of opting these modalities, Botox is the one which could be incorporated into the district general hospital, into the remote areas with a very less training. Even I have done some Botox by the help of the radiologist. Can I do it? And I did it as well. So it is like something which is reproducible, easily manageable as well. Yeah. Thank you so much. We'll move on to the next question, please. You're mute, sorry. Rakesh, you're mute again.
Yeah. Thank you, Dr. Sarfraz. Just a small question to you. What are do you encounter any side effects of botulinum toxin in your practice?
It is extremely safe. It's very, very rare to say something for a modality. Very few modalities you can say, but with botulinum toxin now, almost 3-4 years now, I don't think we have seen any problem with botulinum toxin. So I think it's very safe, and the reason is because you're injecting into the muscles. We're not going beyond 300 units, and the dose is very low, and the inadvertent introduction into the vessels is probably a very circumventable and preventable problem. So that is why I think nobody has reported, even if you search for the literature, I don't think anybody has reported any severe side effect of a botulinum toxin given for abdominal wall reconstructions. So I think it's fairly safe, Rakesh.
Yeah, thank you.
Yeah,
Thank you.
yeah.
So
Yeah,
my
just
next
only
question
one thing to
to
add on, Rakesh, just to add on one, we have a checklist as well. We all of our patients go through the AWR-MDT, and if the patient is going for a Botox, we have a checklist as well. The patient should not have a muscular dystrophy, a neuromuscular disorder, skin infection, or any known allergic reaction. So these are the 3 or 4 questions which is into the consent form as well to pass through it, and then the patient go with the Botox. They are not reported as Dr. Sarfraz had said, but we do it through the MDT, like to go through these questions. Yeah.
Yeah,
Thank
thank you. So my next question to Dr. Sujit. Sujit, are you here?
Yeah, I'm still here.
Yeah. So we know the defect size is one of the most important factor influencing our mesh repair in the hernia surgery. So I would like to ask you 2 questions. So in your practice, is there any incisional hernia you still considered suture repair? And the next question is, when you see the algorithm of complex hernia, so when the midline defect you cannot close, so when you try to, I mean, when you considered escalate for anterior or posterior component separation, or considering the bridging repair in this scenario?
Okay, I think I will answer this in a slightly different way. There's a question from the audience about low resource setting. So let me answer that for a low resource setting. So uh, uh, your first question, whether I use a mesh. Any incisional hernia, I would like to use a mesh. Only place I don't use a mesh is if it's a primary umbilical hernia, umbilical up to a centimeter. And beyond that, usually I use a mesh. And this is supported also by the guidelines. And the second part is 1 to 3 centimeters. If you are in a low resource setting, you can do open prepared. You just need to go into the pre-peritoneal plane, and then you can put a standard polypropylene mesh. And if you have laparoscopic instruments from 3 to 6 centimeters, you can do a TAPP and close the defect and do a TAPP. And beyond 6 centimeters up to 6 to 8 centimeters, TAPP is not going to be very effective. So this is where you need to try your ETEP skills. Okay, and sometimes these ETEPs you may need a time. Beyond 10 centimeters, don't try lap. If you're in a low resource setting, just do open, and you may need bridging. And if you do a tie, you still can't get the things back together. Use your peritoneal side. Preserve your peritoneal side. The paper is coming out soon. So preserve the peritoneal side. Use it for bridging. You can use it for anterior repair. You can use it for posterior repair. Mostly we use it for the posterior layer reconstruction. But if you really need, you can use it for anterior reconstruction. Okay. For so I spoke about low resource. So now I speak about say a first world country, for example, Singapore. So basically what we do for 1 to 4 centimeters, we can use something called the open IPOM technique. There are special measures, composite measures available. We can use these to repair these defects with a small scar, especially those umbilical hernias. From 4 to 6, we still do IPOM plus. If we're in a good mood, we still do ETEP. Between 6 to 8 centimeters, this is where your botulinum toxin comes into. So Botox, if you are in a good mood, do IPOM plus. If you are in for some excitement, you can do a ETEP. Beyond 8 centimeters, you need some sort of we have closed defects up to about 8, maybe 10 centimeters with Botox, but beyond that, you need some sort of component separation. So mostly these cases end up with a TAP. And beyond 12 centimeters, laparoscopy is not a very good option. So this is where we do open. Yeah, over. Thanks.
Yeah, thank you. Thank you, Sujit. Now Sajid, it's your, you can proceed
Yeah,
now.
sure. Thank you. Thank you. Before moving on to the next question, let me just take an opinion from Dr. Zheng Ji as well as from Dr. Alexander as well. What modalities are you practicing Botox as well as the pneumoperitoneum or the flap techniques in your practice as well? Dr. Alexander, you first.
Yes, of course, we use botulinum A, but I said in the start of our discussion that we have some organization problems with these. We don't have official indication in Russia drugs of botulinum A that we can use it for prepare. So we usually use special scientist program when a patient signature that he or she agrees to take participate in this investigation, and for legal we do like this. With memoperitoneum, we have a problem that we don't know who will pay for this patient. Our insurance company, we don't have this type of procedure for payment, yes, in Russia. So in very rare case, we use a pneumoperitoneum, and FAB technique, it's very usually procedure for in our practice, and sometimes we think that it's a good decision to avoid tar separation in some case, for maybe for most quick operation.
No, that's great. Yeah, thank you, thank you. And Dr. Zengi, what's your view on it, please?
Yeah, I mean, ask the Botox.
Extra modalities, not the Botox only, extra modalities for the larger defects.
So there are a lot of, I think the options for us to, if we have the cases very difficult to close the defect, we can use some additional technique like TAR, Botox, PPPD, or some, the peritoneal flap techniques. Yeah, but I think there is a trend, towards the minimally invasive and refined development in China, but specific strategies are still highly individualized, I think, So for IPOM to ETP or TAR, this is one trend. So since IPOM, the problem is there are some, the mesh erosion or some sepsis or something like that, yeah, is one of the problems. So the surgeons would like to put the mesh between the layers of the abdominal wall. So however, for more complex cases like a large defect, recurrent the hernia, so more advanced MIS, the technique such as complete ETP or TAR has advantages in reducing the post-operative problems, in shortening hospital stay compared with IPOM, however. So the overall trend is that in some big centers, especially like in Beijing, Professor Chen Jie, and some university hospital, the indications for MIS is broadening north from traditional IPOM to more complex surgical procedures such as ETP, something like that. So what is the upper limits of the defect size of pure MIS? I think in China, our standard is 12 to 15 centimeters is in the general consensus. But it all depends on your technique, you are skillful surgeons, of course, yeah. And also the laparoscopic techniques is sophisticated, no problem. Yeah. So the routine clinical practice is the guideline-based first. Yeah. And then the individualized decision-making process. Yeah. So for my decision-making is the first we have to the image first, the evaluation, like CT scanning, to accurate the measure, the defect size, also to calculate the ratio. And the second one is prehabilitation. If some cases are very difficult, we have to prepare the patient, perioperative. It all depends the defects, how much big enough. And the third one is the general condition optimization. So like blood, the blood sugar controls, and also BRM, the management of lung disease or smoking cessation. So the second step is the stepwise selection of surgical strategies. So if the defects less than 15 centimeters with severe loss of doming, so pure laparoscopic surgery is preferred, of course, and but in qualified centers, I just said that. So if the defects between 15 to 20 centimeters or with moderate loss of doming or adhesions severe, so I think it may be the hybrid approach, laparoscopy with open surgery is the good choice. So if the defects more than 20 centimeters or severe loss of doming or very dense adhesions in abdomen, so open surgery is preferred. So usually with transverse abdominal release like TAR or some tissue structure separations like this. So, but we have to care about post-operative the intensive management. So preventing abdominal compartment syndromes, this is the one big problem there, and also prevention some infection and seroma. Also the long time follow-up is also very good option for us to evaluate the results of the operation. So in summary, I think the management of complex abdominal wall hernia in China now is developing rapidly towards minimally the invasive and precise. So IPOM is still the most widely accepted, but new technique like ETP or TAR are emerging. So upper limit of the pure MRS, I think it may be the less than 15 centimeters defect. So the core of decision making is a strict preoperative MDT in the evaluation, especially the active application of Botox, like just Dr. Bai said, to combine with other like PPPD, pneumonia and the gas in the abdomen, and also in China we have the volume vented, vented. That means you can remove some omentum or some the solid organs like a spleen to get enough space. How to call that? It's a volume reduction, like that. It's a very controversial technique, but introduced in Beijing by Professor Chen. But for some severe cases, we still can use such technique. Mm-hmm. So all this which is the corrections, is the cornerstones, the very important stones of achieving minimally invasive repair and reducing complications. So thank you.
Thank you. I think we'll move on to the next session, next question. Dr. Sipras, from you, please. When we talk about the ventral hernia, I think we have spoken a lot about the ventral hernia. Let's move on to the lateral ventral hernias. So the lateral ventral hernias are the ones which are more challenging, not only due to the anatomical plane distortions, but also because of the complexity, because of the rarity, because of the previous procedures, and they need to be done in an expert hands as well. So what is your preferred plane of dissection and fixation strategies to ensure a durable repair in these patients?
Sajid, are you talking to me?
Yes, sorry.
I'm so sorry. I did not realize you're talking to me, but you can say that again. It is going
no
to
problem.
refresh my...
I think no, no problem. I was saying, like, we have spoken enough about the ventral hernias, midline hernias, strategies for those and everything. So if we move laterally, let's talk about the lateral ventral hernia, which are more complex, not only because of the anatomical distortion of the planes, because of the complexity, because of the previous surgical procedures. So they need a more expert hands in terms of the repair, in terms of the durability of the procedures. So what are your fixation strategies in terms of the planes as well? Like we know that multiple planes, different people go into the different, we are not talking about with parastomal hernia, we'll talk about it without parastomal hernias going into the strategy.
Yeah, so Sajid, you know very well that subcostal hernia has been my
Yes.
favorite area of
Yes.
interest because I find that area very, very difficult and challenging initially. And then I thought that we must crack it. And there is, of course, something that we do nowadays. We emulate the Edinburgh technique, so to say.
Yeah.
But to first start from where it should be started, all these non-midline hernias, the boundary hernias, the lateral hernias, whatever you might like to call them, they are
Yeah.
more difficult to treat than the midline hernias. A, because your fixation of the mesh is going to be a problem. If you're thinking onlay, where do you fix? If you're thinking IPOM, where do you fix?
Yeah.
So that is the number one problem for a very average general surgeon. The problem is that in these non-midline hernias, your conventional methods are not going to work.
Yeah.
Even if you did it, the chances of recurrence is possibly more higher, arguably more higher.
Agree.
And then we have this problem specifically in subcostal hernia that you will have a denervation atrophy of the muscles downwards. Similarly, in a lumbar approach post nephrectomy, you might find that the entire muscle is denervated. So there will be a lot of denervation, muscle atrophy. So what are you going to reconstruct with when there is nothing, there's no brick, there's no wall, as we all know. So the challenges in these lateral hernias are immense. So that is why the EHS guidelines say it has to be a sublay repair. It's easier said than done. But the sublay repair for lumbar and right iliac fossa could be a TAPP approach, could be a transabdominal partly extraperitoneal approach, TAP. You could do ETAP, ipsilateral, do that, and you can do open surgery depending on how big this defect is. For subcostal hernia particularly, they come to us following an HPB surgery. It could be a cholecystectomy, it could be a liver resection, it could be liver transplant. So it's a precarious surgery because there's something more important and precious below, and the chances of injury is high. So what we think, based on our earlier experience, and then when we change, when we compare, we find that we moved away from trying to go pre-peritoneal because the injury rate with diathermy was higher. So we now stay at a different plane. I'll come to that. And number two, one of the defect margin in subcostal is the costal margin itself. And very little tissue is available from there. So getting it apposed, defect closure, is sometimes just a distant dream. Therefore, these two major problems, the injury rates are higher when you start operating, which is not good. Two, you can't oppose these defects. So we thought, what are the alternatives? When we looked at the Edinburgh repair, which is an open repair for large subcostal hernia, it appealed to us. What we do is we create left retrorector space, right retrorector space, and the external oblique and internal oblique plane, rather than going into the pre-peritoneal or pre-transversalis plane by doing a TAR. We stay between a plane between external oblique and internal oblique. These are robust planes. And then we connect these spaces from one retrorectus to another retrorectus, just a crossover if we do in ETAP. But when we start from EO-IO plane to the retrorectus, one may argue, aren't you cutting the neurovascular bundles? And the answer is, the subcostal incision has already divided the neurovascular bundle. There's nothing more to cut. So what you get now is robust muscles at the top, a posterior rectus sheath, falciform, again a posterior rectus sheath in the center. And on one side, you get internal oblique and transverse abdominal. So you get very, very robust muscles to place the mesh in this. Plus, we do not sacrifice the hernia sac. We use the hernia sac, one half for the top, one half for the bottom. So we keep it connected like that. And once we do this way, we have found that we get less injury rates, very good, easy to replicate, reproducible technique. And we also get a fair bit of very low incidence of recurrence. One might argue, why do you think that the peritoneal flap, which is just the hernia sac, how will it have the robustness? And the
Yeah.
answer to that question is the proof of the pudding is in eating it.
Yeah.
Why it happens? There is a lot of hypotheses. There was some study done in India in 1990 by Dr. Matupurkar, who showed that if there is a mesh in the peritoneum, it will cause metaplasia and lead to aponeurosis, which is probably why it is more robust than we think. And finally, smaller subcostal hernias, nowadays we do ETEP technique. We start from the left retrorectus, we migrate, and then we do ETEP sublate.
ETEP technique. Yeah.
So this is, in a nutshell, what we do.
Yeah. Thank you so much. I think that's a very comprehensive answer for the audiences. For the sake of time as well, we cannot go to the whole subject plane in terms of the whole discussion, but that is the overview, good overview about the lateral ventral hernia. I won't go into the details of the parastomal hernia. That is the entirely different territory and different subject to be discussed some other day. So we'll move on to the next session. Rakesh, to you, please.
Yeah. So thank you. So my question to Dr. Sarfraz, and first I would like to congratulate him for propagating the peritoneal flap hernioplasty, especially in Indian subcontinent and definitely to Asia, and publishing a huge amount of work. I mean, especially the TAR and TAR plus and PFS, the multi-centric study, which I read, and what I found near about in 70 patients with huge hernia. I mean, maybe some of them are in this stage with the recurrence rate of 0 and patient satisfaction reaching up to more than 95%. So my question to you is that what is the selection criteria for these, I mean, PFS technique, and how you teach this to young surgeon? And does it require any fellowship kind of thing for this peritoneal flap, or I mean, because if you see the diagram is from the Edinburgh group, is, I mean, slight tricky to understand in the initial phase. Yes.
Yeah, thank you, Rakesh, for your kind words. And I would like to start from this line saying that sometimes simple things are unbelievable. Peritoneal flap technique falls into that category. I have gone across the globe asking people whether they do it, and they say, no, I don't. Why? Because they think it's a bridging repair. Fair enough. But unless one tries in a multi-centric fashion, or you try it on your own, one would not get confidence in it. The Edinburgh people have published more than 200 cases with a good follow-up, and they showed that this works. Why this works? A lot of hypotheses, but it does work. And peritoneal flap technique can be learned in 5 cases. Once you've done 5 cases for the midline, you will have a fair bit of an idea, because you're cutting the anterior rectus sheath so that, and you get into the retrorectus space so that the hernia sac becomes a continuation of the posterior rectus sheath. That's the line to understand. Similarly, when you cut the posterior rectus sheath to enter the retrorectus space, the peritoneal flap or the hernia sac becomes a continuation of your anterior rectus sheath. If one can understand this line, and you can do that in your practice, you will get the idea of what this is. Now imagine the major advantage is, once you do peritoneal flap and you believe in it and you get more confidence, you are able to manage small cases to very big cases, because the peritoneal flap itself increases the abdominal circumference. It is contributing to the increase of the abdominal circumference.
Yeah.
Where is the other technique which does so? If you do TAR, you're doing medialization. If you do fascial traction, you're trying to, avulse, or let's say, elongate the muscles. We do that and it works. Again, for strange reason it works, but you're elongating the muscles. You still need an apparatus, an expensive gadget. Here, we are not using any gadget. We are using hernia sac itself. But when you say peritoneal flap, I would like to say here, this is just not the hernia sac. It is the denuded. You take away the epidermis and a little bit of dermis, everything else left with the hernia sac is there. So it's not exactly only the hernia sac. It has a little bit of fat, it has a little bit of dermis, it has a lot of strength. You try to avulse it, you can't avulse it. When you oppose it, you will find your sutures are staying there very well. So that is when you do for midline. For lateral hernias, we almost always use it. So when you say indications, whenever we're doing lateral hernias, it's very difficult to oppose them. We almost always are able to use the peritoneal flaps in these cases. For the midline, we divide into 2 groups. whether we are doing botulinum toxin or not. If the patient is affordable, insurance is paying, botulinum toxin. Patient not affording, insurance is not paying, go directly for the peritoneal flap technique. So this is how we think. But intraoperatively, even if you've done a botulinum toxin and you are doing reef stopa and you find the reef stopa is not enough, you want to do a TAR, well, take the help of peritoneal flap again. So peritoneal flap is always available. The hernia sac is always available. In our cohort, in about 7 to 8% of cases, we are not able to use the flap because maybe we have devascularized it, or it's too thin, or there are Swiss cheese pockets and they're not flat. So those are the patients where we do not use it. We are not able to use the hernia sac. And another indication where we do not use it is, let's say there was a previous hernia surgery, it went bad, there was a post-op wound sepsis, there was probably a gut breakdown, ET fistulas, and in that area, there would be organisms, and there we would like to have something like an R0 resection before going for the second repair. I will not use that peritoneal flap. In any patient where there was a mesh sepsis, gut injury, enterocutaneous fistula, we are a little scared to use those peritoneal flaps. So I'm echoing my thoughts about when we are not able to use it. So it's less than 10% cases where we can't use it when we wanted to use it. In rest of the cases, you would almost always be able to use the peritoneal flap.
Thank you very much. I mean, hopefully in future we can run RCT on this project.
Yes, we should. And I think with our growing confidence, not only in one center, we have 3 very large volume centers now, including ours, where we do this regularly in Aligarh and in Delhi and in Calcutta. And I can tell you that we have started some time back, and after the publication also we've added so many cases. We think it's a great procedure. The only issue is, since it is emanating from here, we will have to publish good quality data like an RCT to ensure that the rest of the world recognizes. Obviously, the Edinburgh people have said this, and Scandinavian people have been doing it for years. And even I think the rest of the globe does it without calling it the peritoneal flap technique. They just say that we've utilized the hernia sac to cover the mesh or posteriorly or anteriorly, but they don't use the term. So once we have some uniformity of language and we start saying that these are the methods being used, and post-operative follow-up, we start evaluating for pseudo-recurrence and recurrence through our CT scans, I think we'll have a robust data to show that this works in a large majority. Of course, everything comes with a price, but this will work in the large majority. It's a simple solution for an Indian subcontinent where we are resource hit, we are budget, we have to look at the budget. I think this is a great technique to adopt.
Thank you very much. So Sajid, now it's your turn to proceed further.
I think we'll skip the next question from Dr. Sujit and Dr. I'll ask as well one more question from Dr. Sarfraz before moving on to the next question. I think we have discussed a little bit earlier from the beginning that we have addressed about the issues which you said earlier, like one is the training, second is the MDT. So in a real-time decision into the operating room is always challenging. We know about it, and then we have seen the result. I have worked into the 3 different parts of the world. I was trained in Pakistan, and then went to Singapore to do my fellowship training and working in European side. So I have learned the thing that the shift is still in practice into the different region. So all our cases, as I said earlier, complex abdominal wall reconstruction, they go through the checklist, they go through the abdominal wall reconstruction, MDT. So if I talk about, I go back to Pakistan as well sometime to do the cases as well. So if working in Pakistan, so the patients are not going through the AWR MDT. So it's a single person based decision. So what is your opinion and perspective like to build an effective, how to build an effective AWR MDT, and what point should be involved into building a team in the South Asia or Asia Pacific region?
So allow me to be very honest and candid on this issue. Right now, it is the single surgeon phenomena as far as hernia is concerned. I'm not sure about what happens with Alexander and Dr. Zheng Li, but in India, I think most of us, we love to say that we should have an MDT, but the honest confession is, generally, The MDT is more like a phone call to your anesthetist, a phone call to your, your nutritionist, and a phone call to your a pulmonologist sometimes, a diabetologist sometimes. So it is not exactly sitting in one room, looking at the patient and looking at the papers and saying, okay, this is the pathway we are going to take. So there is at the moment a non-uniform, non-standardized, a haphazard way of doing this in the Indian subcontinent. But we are gradually progressing. I think many centers now, including ours, when we see patients, I would probably be the first person to see the patient, obviously as a surgeon, and I will write down various points of concern in terms of patient factors. I will have a line in my impression where I like to write down the patient factors, the wound factors, and the hernia factors separately. And then I'll write down the CT scan finding. And I'll write out my plan about the preoperative strategy from a surgeon's point of view. And when I refer, I will refer to my multidisciplinary obesity clinic. So right now we have two clinics which were not there earlier. Cancer multidisciplinary clinic came years back, but the obesity multidisciplinary clinic came recently. And now we can refer to them and say, take care of the obesity. And then they will refer you back. Similarly, we get the anesthetist and the radiologist. One of them, in our case, anesthetist for doing botulinum toxin and also to assess the patient time. And again, so they get involved pretty early. They get involved pretty early with the case. So one is the obesity team, one is the anesthetist come radiologist who's also doing botulinum toxin, and we are all going together. And then there's a conference call at some point of time where we are all talking about, okay, this patient now looks better optimized. He or she stopped smoking, HbA1c is in a better level. She's done, or he or she has done spirometry, and they're looking good. And I think this is the best window we will get. We don't think we need to optimize this patient further. So I think those things are beginning to happen, and they will crystallize sooner or later into physical meetings. But that will take time, and it will happen only in a very few centers. This is my premise as well as my guess. So yes, honestly, this is what is happening, Sajid.
Yeah, no, exactly. I think still we will call it like I won't call it the best interest meeting, at least a mini MDTs are still happening, not a complex AMDT are happening, but mini MDTs or best interest meeting with the patient involvement and all these people. And also I think the results I have seen it, like addressing the obesity, and then one neglected issue which we haven't talked about so much, which I've seen in these three parts: nutrition of these patients and smoking. And smoking, I believe, like is a top onto the top of the list, is a killer when you are doing a lot of dissection and placing a mesh in these patients.
Yeah, absolutely. I think smoking is not a huge issue as now we are. I think I can say this on the public forum now that for smaller hernias, maybe it doesn't make a big difference, although we tell them to stop. But for large hernia and huge repairs, it does make a difference, and we must be very, very religious about getting them to stop. But on a practical level, it never goes down to zero for many patients. Smoking is still there somewhere.
No, of course. I think for the NHS England, this is a very, very strict rule because now the patients are passing from the AWR MDT. If they are still smoking, they would not pass through the AWR MDT. So they would not get because it's a NHS is being funded by the NHS England, so they won't support these patients if they're still smoking.
I would like to know what Alexander and Dr. Zheng have to say for that, whether that happens in their country.
For me, it's really a surprise that England guideline that if a patient smoke, he couldn't get operation for big hernia. But it's I think it's not bad because really smaller it's a very big problem, and I think we are on the way, like, and oncologist, obesity surgery, that we need a big team for prepare and rehabilitation for our very, very difficult patients, because we know these patients not difficult hernia, it's a difficult comorbid status. So for I don't want to spend a lot of time. I agree with everything with Dr. Safaros.
Thank you. Thank you. Thank you so much. Yeah. Dr. Rakesh, to you, please.
Yeah, thank you. So my next question to Professor Zen and Professor Alexander, like both of you work in a very high volume center and producing large amount of skill workforce for your country. So my question to you, does your training program is have any systemic structure, and is there any fellowship program for the surgeon across the border? Professor Zen?
You mean about training, right?
Yes, yes. Training program and any
Yeah, the
fellowships.
training program, in China, it's very popular. We have many societies, and every year, a lot of organizations, the programs, hands-on or even TV show or reading on live, something like that. But I think the core difference between the high-performing the surgeons is the ability to make systemic, individualized, peri-operative the decisions, not just the surgical skills. So this is there are some levels. The one level is the accurate pre-operative assessment and risk stratification. Yeah. So we have to evaluate the patient very carefully. The second one is the ability to select individualized surgical methods based on the MDT. This is so just talk about the MDT is very important. The team always stronger than the one individual. So the third one is the deep understanding of functional reconstruction rather than the defect repair itself. So functional reconstruction, the conception is very important. So how to systematically cultivate some decision-making ability. So the training practice is very, very important. So just as I mentioned. So the training, the program should be standardized, theoretically courses and simulation trainings like, I think the APHS, our society is very good, because in the different, more than 40 countries every year in China, I think we have essentials, also the advanced training courses. So very good examples. The other one is the clinical fellowship in high volume centers. So there are some, the training, the centers excellencies. In China, we have two. One is in Beijing, the other one is in Shanghai. And also, I remember in Singapore, India, and other places can provide the clinical, the training programs. So you can get some certificates. The other one is international, some the senior specialist certificate like EHS, and I'm quite familiar with German hernia days, also International Hernia Society, and there are some training program and very good arranger. So I think training is very, very important. But should be standardized and also, very famous experts to give the lectures. Yeah, this is my opinion.
Thank you, Dr. Zen. And Dr. Alexander, your view for systemic training and fellowship programs in hernia surgery.
And China, we have some, also not only talking in Chinese, but also there are APHS, I think every year at least 2 times in our country. Yeah.
Thank you.
Yes, it's my answer. For my opinion, the most important factor is a surgical judgment in decision making. And first of all, it's for our students, fellows, and young doctors. We have some programs that, first of all, it's theoretically part. They should know why, in which case they choose this or those technique. And that's why my students, they read a lot of articles for understanding the decision making. And if we speak about technique, it's developed through stepwise training and gradual mastery of different techniques. For my opinion, young surgeons should start from TPP. It helps to develop intercorporal suturing skills. Then, my opinion, they should make IPOM technique to teach how safe manage difficult situation, for example, after ETEP or something else. And then they should learning for ETEP for inguinal hernia as excellent way to understand a safety walk in the extraperitoneal space. Beyond technical skills, a surgeon must clearly understand what they are implanting, meaning a deep knowledge of mesh materials and their behavior. We are we are combine our program is built exactly on these principle progressive development of both technical skills and surgical judgment, and we make fellowship programs for surgeons from another countries too. And I want to say for you some Russian maybe jokes or not jokes from our old professors and surgeons. They every time told to us that if you can properly repair a hernia, you can perform any operation. So I think that it's very important to study our young surgeons to make to do good hernia repair.
Yeah, thank you. Thank you. So, Sajid, you can proceed further.
Yeah, please, you can ask a question from Dr. Sarfraz about the
Yeah.
session, please.
So,
Because of the time, let's move on.
next question to you regarding the robotic surgery. As we know, in AWR, the robot is coming in a very big way, and especially in the difficult scenario, robot definitely works a lot. So, what's your view regarding its penetration, especially in the Asian subcontinent, and how to progress with the training to young surgeons?
So robotic surgery is definitely making a lot of noise. I'm just going to state everything that is happening before giving my own personal opinion. So first, it is creating a lot of noise in the Indian subcontinent. There are in every city, all hospitals have purchased a robot. It could be a Da Vinci or it could be an Indian model as well. Second thing is that the price for the robot is coming down because the Indians are also making it, and we are also now importing robots from China. This is going to be there in the next 2 to 3 years, a larger phenomena, and we will see a fall in the price of the robot. The robotic consumables are very costly, which prevents most of us from using it in large number of cases. So the who pays for the robotic consumables is a big question in India. The insurance is not willing to pay for everything, although on a daily basis we see an evolution in insurance. So recently the insurance incorporated paying for the robot for some hernias, not for gallbladders. So I'm just talking about general and GI surgery. I'm not talking about uro or gynae. So these are certain changes that we are seeing. Also, from a surgeon's point of view, we are also in the process of learning the robot for various procedures. Of all the procedures that I see and witness and I do, I think it is very useful for anything on the entry abdominal wall where a lot of suturing is required. So ventral hernia surgery is one place where its use will translate into clinical benefit. When having said that, to learn the robot, we will have to do cholecystectomies, we will have to do groin hernias. This will also help us in learning how to use the robot. Before we embark on doing far more complex ventral hernias with the robot. So in nutshell, I think we will see far more robotic hernia surgery in the future. We will get to see more insurance paying for it. We'll see cheaper robots. We'll see more trained robotic surgeons, and it will translate into clinical benefits for ventral hernias. I think may not translate into clinical benefits for others, but it will translate into clinical benefits for ventral hernia. So those are my observations and my own personal opinion.
Thank you, Dr. Sarfraz. Sajid.
I think because of the sake of the time, we will be shorting the duration and the number of questions as well. So I will just move on to the last question from the whole faculty. Like we know that we are moving forward. In the beginning, I've asked about the single most under-addressed issue. So now we have seen that there is a lot of things going on into the APHS. We are writing up the guidelines, and EHS is doing a lot of work into the complex ventral hernias as well. So what we are looking forward, a single most, I would say, important research question that needs to be looked forward or addressed, because audience, there are a lot of people listening to us, and this whole recording would be uploaded onto the YouTube channel. They would be listening to us as well. So what is the single most research question we should be looking for in the next 5 years? So I think I'll start with Dr. Alexander. We'll move to Dr. Zhang and then ask Dr. Sarfraz as well. Yeah. Thank you. Yeah,
Thank you,
Dr.
Malik. Thank you, Malik. Yeah, if I had choose only one key research question, I think it would be this, that where is the limit of minimal invasive surgery in complex hernia? And does it truly exist? Because today we're rapidly expanding indication, but we still lack clear evidence on long-term outcomes and proper patient selection. So for the next maybe 5 years, we need not only new techniques, but better understanding of when and for whom we should use them. It's my opinion.
Yeah, okay. No, that's very good. Absolutely. We will send a follow-up email about the questions as well. Yes, Dr. Zengi, please.
Yeah, I think this is very critical, the questions, because it directly addresses some, the challenges. I think in our Asians, the most important is we lack of our Asian population specific evidence, because international guidelines are mostly based on European or American data for our Asian patient, the different size of the body size, abdominal wall anatomy, or even the common hernia types. So commodities, spectrum, the different, socio-economics. I think we have to get the Asian guidelines, the specific evidence-based, yeah.
Okay, yeah. And Dr. Sarfraz, what's your opinion about and the address issue and the...
Yeah, I think the most important research that we need is how to prevent incisional hernias. How do we suture the midline laparotomies well? This is a very important question because 15 to 20% of our laparotomies are having incisional hernias. That is huge. So we need to find out ways. I know that the different suture materials have come into the market. Small bites were there always. I always felt that the 30 millimeter PDS was not working in our hands for many cases. So we can't refute the data, but I think we need to change the suture rather than change the needle. The needle needs to be a little bigger. Sometimes that's what I feel, my personal opinion. Second, I think the problem is the treatment uniformity is lacking. And I think that is not going to get solved very easily. But the question that needs to be answered is whether MIS, I think I agree with Alexander and Dr. Zhang also, that whether MIS does translate into better outcomes. We are spending so much of time, energy to do MIS, large complex hernias. But what if the open surgery gave better results, more satisfaction than the MIS surgery? Why would we invest so much of time, energy, and money into all of that. And so we need a head-to-head comparison. I know hernia search, there was one where it showed different kinds of repairs for incisional hernia, and they showed open reef stopa and IPOMs were doing better than the rest of the repairs. So they had their own pros and cons. But I feel if we can teach our surgeons open reef stopa for lots of patients where IPOM is not suitable, make that shift, use peritoneal flap, make that shift. I think we would be able to have a lot of cases under open surgery with very good results. MIS, yes, use MIS, but think of hybrid. It makes things simpler. It's just because there's a lot of people doing something in one way. There's a lot of glamour in one way. We think that is what is going to work for us, but we need data, robust data to say, okay, if we do this, it's going to translate into benefit, and we don't yet have that data.
Yeah, no, I completely agree. Thank you so much. I think I was thinking, in my opinion as well, I was thinking about the new material which we have already started using it. Might be being used in your practice as well, Duramesh. So we are using a Duramesh for the closure of the abdominal walls now. So which is giving a very good result. So let's see what will be the future. So this is my opinion, like looking for the question for the new modalities and for the simple repairs, why we are getting for the incisional hernias. I think with this, we will come to the end of this session. And I think it was an absolutely fabulous and extraordinary discussion from the whole faculty. And we want to thank you to the extraordinary panel, Dr. Sarfraz, Dr. Sujit, Dr. Zhenglingji, and Dr. Alexander. Your insight have been invaluable. Thank you, Prof. Dumanto, for joining us as well. I think we will request Professor Dumanto again for the vote of thanks, and then I think we will conclude the session then.
No, please. Thank you. Thank you very much. I think it was a great discussion, very, very entertaining. I enjoy everything. Thank you for joining us, and thank you, Sajid, Sarfaraz, G, Rakesh, Alexander, newcomer, and I hope we have more. What is the next episode, Sajid?
The next episode, there are 2 episodes coming up soon. Our next one is on to the artificial intelligence and robotics in general surgery in general. So
Okay.
and the second is about the using the social media in corporations. So
Okay.
patient data and social media being used or not being used into the surgical practice. So where we are standing. So these are the 2 which be coming in next 4 months. So we'll be like in 6 weeks and 6 weeks time. So we will be in touch with everyone. And thank you. The whole recording would be available onto the ELSA YouTube channel. And you can watch it. We will share the follow-up details. And thank you for joining from, like I've seen into the discussion from Africa, from Asia, Asia Pacific, few people from the Middle East. Thank you so much. Thank you for
Thank you
joining.
very much. Thank you also.
Thank you.
Thank you.
Thank you, colleagues.
Thank
It
you.
was
Thank you.
nice. Thank you.
Yeah, I think we